When Jeffrey and Cher had both mentioned that earlier this year they had been out visiting with some of our doctors, and in a couple of the practices, doctors were using subcutaneous pellets for hormone therapy. And the doctors had indicated to them that they liked it because the women liked it, and also it was a source of a revenue stream because it was a procedure that they were doing in their office. So we have invited and are excited to hear our next speaker, Dr. Gino Tutera. MD was born in Rome, Italy, and grew up in Kansas City, Missouri. That must have been culture shock. He received his medical training at the University of Missouri in Columbia and went on to become chief resident at St. Luke's Hospital in Kansas City, Missouri in 1974. At the forefront of his peers, Dr. Tutera opened his first clinic devoted to hormonal replacement and PMS in 1982 in Kansas City. Years later, he branched out to other office locations in California and the surrounding Scottsdale, Arizona towns. And we are very excited to hear from Dr. Tutera today.
I want to thank Immunolabs and the rest of the sponsors for inviting me to come and speak. My emphasis on this talk is to maybe shake the trees a little bit and get rid of some of the dead leaves that we've been carrying around in our brains for a while, because of the fact that we've been taught some things that really are bad medicine, especially in the realm of hormone replacement therapy. If in fact we would apply what we've been taught as goals or endpoints for other forms of disease processes, we'd be ridden out of town on a rail, because of the fact we're taught with hormone replacement therapy that symptom relief is your endpoint. When I went to school and when all of us have gone through training, our goal was to teach to each one of us and to all who follow that our goal is normal physiology to be restored in that patient. The difference is immense. Just giving symptom relief is like asking someone who you just treated for a urinary tract infection to stop their antibiotics in a day because their symptoms became better. That's not curative. The same way for us. In hormone replacement therapy, our aim should be biological, physiological normality. The pellet therapy is designed for physiologic normality because when you're physiologically normal, you no longer have the problem of being symptomatic. I'm going to present to you this technology that basically has been in the United States since 1939, and basically when you saw Dr. Mead's slide about Wilson's book coming out in '64, that was almost the death knell for the usage of this technology other than at the University of Georgia and LSU University Medical Colleges. Because in '64 it became much easier to write a prescription and send your patient out the door and cure her menopausal symptoms when we should be and always should be creating normal physiology. The pellets are the only form of hormone replacement therapy that the body can actually control the release of the hormone. The release of the hormone is basically metered by cardiac rate and output. If you think of a pellet, well, if you think of this as a pellet, once it's underneath the skin, it's surrounded by a myriad of blood vessels. As your heart pumps blood across this, your body becomes like a child licking a lollipop. So therefore, during periods of high stress, or whether it be physical or emotional, you're going to have an increased release of hormone, and during periods of rest, sleep, you're going to have less. So therefore what happens is that you get a continuous release of hormone, which is unlike any other form of hormone delivery. And this basically reproduces what the human gonad would do both in men and women. If, in fact, that is not your endpoint to replace a altered physiology with a normal one, then this isn't a technology for you. Let's talk about some of the things, that this is advertising here. If we're going to talk about what would be the ultimate hormone replacement therapy, well, first of all, we want it to be biologically identical. But my definition of biologically identical goes far beyond just the usage of the hormone itself. If it's to be truly biologically identical, then it has to be, not only the structure of the hormone needs to be identical to what the human body produces, but it also needs to be in the proper human ratio. Because in order to maximize the benefits of any hormonal delivery system, it should be reproducing the normal human ratio. Thirdly, it needs to be a delivery system that secretes hormone directly into the bloodstream, does not utilize the liver for any form of first-pass metabolism. And lastly, it has to be a system that can amend itself to individual dosaging. If you can't do that, then you really are not doing a complete job on bioidentical hormone replacement, if you are not employing those parameters as part of your therapy. What else should it do? It should be there when you need it. And that's the beauty of using hormonal pellets, is that unless your heart has stopped or you're out of pellets, you don't lose your hormonal levels. They may start decreasing towards the end of the life of the pellets, but you don't have any interruption in flow. And if you think of the endocrine system doesn't stop and start. Unfortunately, we think that as long as we sporadically dose people, that we're going to have this consistent, beautiful level. It doesn't happen in real life. Thirdly, it needs to be absorbed directly, as I said, and not taken orally. So if you want to use sublingual troches and say, well, that satisfies that, that's fine. But once again, you don't get that continual flow of hormone that pellets deliver to the human system. It should be effective. It shouldn't produce a roller coaster effect, because the human endocrinology system does not necessarily produce roller coaster effects in the normal human passage. So as we age, as we become, or maybe a better way is, as we mature physically, we need to have a reproduction of what the human body does, and that is produce a steady state of hormone. It needs to be safe, of course, to have this ultimate hormone replacement therapy, and we'd like to have it as hassle-free, because unfortunately, compliance is a problem. When you're asking people to use cream, it can be problematic for some, especially for men. If you ask men to put on creams using androgel or something like that, they have difficulty after a period of time in being able to be compliant. So, bioidentical. For me, the true definition of biologically identical is not only the same identical structure that each of the hormones we utilize should contain, but it also has to do with ratio, it has to do with delivery system, and it has to do with individualized dosing. One of my favorite cartoons, if the shoe were on the other hoof. Why we think giving conjugated estrogen, why we ever thought that giving conjugated estrogen, giving it to human females was an appropriate thing to do, was beyond belief. Horses produce 17 different estrogens, and Premarin, if you take a Premarin tablet, mush it up in a pestle with mortar and pestle, and add warm water to it, you get this very distinct smell of urine. Try that. It's disgusting. But this is where we started. We started giving people horse estrogen, and because of the fact that it was passed on from generation to generation, we continually, through the emphasis of the pharmaceutical industry, primarily Wyatt Theris, we got lunches, we got pads, we got pencils, and we were continually told about how wonderful these particular forms of delivery were, specifically how wonderful conjugated estrogen was. Just as a reminder, this is how the human body makes steroid hormone. It starts with cholesterol, of course, then it's broken down into these different components. The end point is testosterone and estradiol in women and testosterone for men. I bring this slide to you because if in fact you have testosterone and estradiol adequately satisfied and you're trying to use DHEA or pregnenolone, the precursors, be very careful. Because if in fact you have satisfied this part of the equation, then DHEA has two alternate pathways it can take. One of them to form dihydrotestosterone, the other one leading to 16-alpha-hydroxyandrostenedione. This one, of course, this 16-alpha-hydroxyestrone, the end point of that is associated in a high degree with breast cancer. So be very judicious if you're using certain therapies where in fact you're using a little testosterone, a little progesterone, a little pregnenolone, DHEA. If you combine all those together and this pathway is already satisfied, this will take alternative pathways, and that may be where you're getting problems in some of your therapies. These are the natural estrogens, estrone, estradiol, and estriol. The proper ratio in the human female is estradiol to estrone of 2:1. So if you are formulating something for someone, be sure that it's in the proper ratio. Unfortunately, Biest and Triest do not adequately satisfy that. The ratio from Biest and Triest is either 1:4 or 1:8. The human female needs estradiol for cardiovascular protection, and the recent studies that came out of the National Cancer Institute, supported by and done by Craig Jordan, the gentleman who invented tamoxifen therapy for women, for breast cancer survivors, he has now found that physiologic doses of estradiol will induce cell death in estrogen-positive breast cancer cells that have been metastatic and unresponsive to tamoxifen. It seems counterintuitive, but think about it. When do women get the highest incidence of breast cancer? It's at 50 or above. What has happened in that time? Why aren't you all getting breast cancer at age 30 or 35 or 40? Because you're able to maintain the normal ratio of estradiol to estrone of 2:1. Why don't you get cardiovascular disease? Because that helps you decrease the inflammation in your body, and it reduces that inflammatory response that's unfortunately associated with so many diseases. So if you can find a therapy that can naturally afford you a 2:1 ratio of estradiol to estrone, you have really won the battle. This is unfortunately what we've been giving people in birth control pills. We give them ethinyl estradiol. This is the estrone, horse estrone equilin, which is in Premarin. It has that extra double bond in that carbon ring. And this, of course, is diethylstilbestrol, that abnormal creature that caused vaginal adenosis and vaginal adenocarcinoma in young women. The effects of oral estrogen therapy, basically, if you put it through the liver, you may induce nausea and vomiting, fluid retention, blood clots, because when that estrogen is placed into the liver, it goes through first-pass metabolism. When it does that, it stimulates the production of clotting factors, which increase your chances of getting clots, DVTs, and we don't adequately understand how terrible putting estrogen into the liver, especially the synthetic or horse estrogen. The different routes of estrogen delivery. This is one of the first studies that, this was done by part of Margaret Thaum's study in 1984. She measured the estrone and estradiol ratios in the human female. She found that, in essence, the majority of the cycle was occupied by a 2:1 ratio of estradiol to estrone. When using the oral form, which is conjugated, this is a reversal of ratio that you get with Premarin. It reverses the estradiol to estrone ratio from 2:1 to 1:2. And estrone is a very breast-stimulating estrogen. Patches, low dose, and the high dose, this is the 0.05 to 0.1, you still don't achieve that normal physiologic 2-to-1 ratio. When you look at the doses that we teach in my training courses about the usage of pellet hormone, you begin to see that you get this 2-to-1 ratio, and then we become primarily estradiol-infused women. This is the second part of that study that basically she showed that after implant that this 2-to-1 ratio was kept up until about the 4th or 5th month, and then at the worst it became 1-to-1. Is it biologically available? Biologically available means, is it there when the person needs it, and is it there all the time? Unfortunately, we think that we satisfy a woman's need for hormone by being able to relieve symptoms, and as long as symptoms are gone, then she doesn't need hormone anymore till her next dosage, which is absolutely incorrect. The only way we can actually help women and men be normal is to induce a physiologically normal state, and that means constant secretion of hormone. This basically represents what you see with implants. This is the oral form, that roller coaster effect, whether it be troches or you give a capsule, or if you get, even with sustained release capsules, you get maybe a little wider arch here, but you still get a rapid rise and a fall because of the way the hormone is put together and the amount of mental cellulose within that capsule. And if you give a troche, it follows pretty much along this line. Patches give you what I call a kiddie coaster effect. This is called roller coaster. This is kiddie coaster. Topical forms also give you a peak and valley, which is not unusual for you to then have to use it twice a day to maybe satisfy that patient's symptomatic relief. The implants, on the other hand, give a very constant flow of hormone. It's controlled by heart rate and cardiac output. So therefore, during the period of therapy that the pellets are present, that adaptation is there. So that a patient then will get more hormone during the period of exercise, estrogen and testosterone, and for men testosterone, and during a period of rest they get less, which is what the human body normally does. No other form of hormone delivery can accommodate that. In this study, this was done by Cravioto, and what he did is he wanted to see when the estradiol to estrone ratio, how long it took to get there. It was at 2-to-1 in about 12 hours. It never gets there with any other form. How long did it last? On the average, at least 5 to 6 months. There is no other form that gives you that normal human ratio. Effectiveness of the therapy. Basically, effectiveness of the therapy isn't just my hot flashes are better or I have better erectile function, because we need to be able to do the things that we normally used to do so easily. Without hormone in our brain, we have problems with serotonin production. If you don't have adequate serotonin production, you get more anxiety, more irritability. You cannot get into sleep states like deep REM sleep very easily. In addition, you're going to have problems with making neurotransmitters. If you can't make neurotransmitters, then neuron A doesn't talk to neuron B very, very, very quickly. And the testosterone receptors, both in your parietal and temporal lobe, help you focus, concentrate, help you with short-term memory. If the patients who come in who have cognitive problems have to be evaluated for low testosterone. The same way, just as if you were talking about low libido, if they can't remember well, it's a testosterone deficiency that is stimulating that. So to be effective, we need to be able to measure accurately, because we've never been taught really to measure things accurately. The fact is, when I was going through training, we were discouraged from getting any kind of objective evidence, because you were taught that if you got rid of the hot flashes, you did your job. That is not my job. My job is to make that patient as clinically normal as I possibly can. And in the area of estrogen, you need to be looking at FSH. Because without the FSH, it's very difficult to know if that estradiol or estrone level or whatever in front of you is actually making sense. You cannot modulate your therapy unless you know that it's having a physiological benefit. And I will challenge you not to try and monitor your therapy without looking at things such as the FSH. Now, if you want to measure the other hormones, with salivary, evaluation, and then use the FSH from the blood, I don't have, because the FSH basically is like the hemoglobin A1C in diabetes. It tells you how that patient has been over a period of time, not just when either the needle was in the arm or when they were delivering saliva. The FSH gives you an appreciation of how much estrogen deficiency that patient may have. And this is the studies that they did with this to see how fast did that FSH come down with pellet usage. And using different dosages, of course, the outcome was even at different dosages of estradiol, because of the fact that it was there continuously and that it was in a physiologic dosage, within the first 5 days, the FSH came down and symptoms disappeared. And how long did it last? Basically 6 months. This is a compilation of that last slide showing you that no matter what the dosage of estradiol was, they all had the same effect on FSH, which led me to develop the algorithm that I utilize and teach to my trainees about how to utilize lower doses, because the key is a physiologic dose of estradiol, not just giving it. And Dr. Craig Jordan, the gentleman that I quoted to you from Fox Chase Cancer Center in Philadelphia, stressed a physiologic dose of estradiol induces apoptosis or cellular death in metastatic breast cancer cells who are estrogen receptor positive, which may be counterintuitive, but it explains why women protect themselves when they keep normal estradiol levels at the proper ratio. Over time, how long does this last? Well, it shows in the first, in this slide, it shows how fast these start, descending. And in the first 12 hours, you can get almost a 20 or 25% reduction in FSH, and it persists. The reason symptoms are gone is because the FSH begins to lower, but the symptoms will come back if, in fact, the patient isn't coming back at the proper interval. But even at that, it stays, this suppression will stay for almost 6 months, which is why most patients, females, come in every 4 to 6 months, and for males come in, usually get to about every 6 months rather rapidly. This study was done by Platt, and what this showed was basically that the different doses of estradiol did show a significant decrease in the FSH. What's fascinating, though, is look at these estradiol levels. With half the dose, you almost got the same level, which is indicative of the human body only needs a small amount of estradiol to be physiologic. Our patients, on the average, receive 3 milligrams at the highest dosage, 3 milligrams a month. A month. Not a day, a month. And that sort of piggybacks on what Dr. Mead's his argument was, is that you don't need huge doses of hormone to make the body physiologic. Just once again, just to stress to you how important having a normal ratio of estradiol to estrone is in the human female. How safe is it? Well, one of the things that, I'm compressing about 200 slides here for you, by the way. So when they looked at lipids in using estradiol pellets basically, there was basically no physical change. I have articles, which I'd be glad to share with you, that show that, done by at the University of Florida, Morris and Tilovitz, showing that all the lipid ratios remain normal. In fact, is the HDL improved, and also the ability for the body to lower total cholesterol was markedly improved with the addition of not only estradiol, but testosterone pellets to the therapy. Because, as it was so well put, testosterone decreases insulin resistance. It helps the muscle uptake glucose so that insulin resistance reduces in both men and women, because this menopausal Michelin, as I call it, is due to that testosterone deficiency. And so don't think that just because we're talking about estradiol that testosterone is not important in this mix. In fact, in this study, which was done by Susan Davis, this group of patients, because they had higher body fat mass, were placed on estradiol and testosterone, and the ones with lower fat mass were placed on estradiol only to see if, in fact, there was an increase in body fat from the usage of pellets. And so they studied them for 2 years. And as you can see, there was no increase. And in fact, in this group of patients, there was a significant decrease of fat mass versus fat-free mass, which is muscle. And these are the numbers. And in the estradiol plus testosterone group, we see this significant reversal of that ratio. In the symptom relief columns, if in fact we're talking about symptom relief, and I will tell you that most of mine are better than this, is that symptom relief comes almost nearly 100% with the first insertion. This down here, by the way, in case you're wondering what urethral syndrome is, those of us who went to medical school, when I went to medical school, know that urethral syndrome really is interstitial cystitis. And even those individuals, because of the improved vascularity to the bladder and the pelvic structures, help improve some of their symptomatology. This demonstrates the effect of estradiol implants in perimenopausal patients. This basically, the study shows that they gave estradiol pellets and they had a placebo. And the reduction in perimenopausal depression was significant. Why? Because giving estradiol to the perimenopausal patient who is demonstrating what we would not commonly call estrogen dominance, really, if you keep the FSH from escalating during those periods of estrogen, peaks and valleys, if you keep the FSH stable by even using a small amount of estrogen, you can actually stabilize that, and their depression decreases because they're able to produce serotonin at a much greater level. The constant secretion and not the peak and valley effect that you get is what helps the brain produce more serotonin. I don't know if in the slides that you can get, the articles are listed underneath here as well. But in this particular study, what they did is the bigger the box, the worse the symptoms were. And within 8 weeks of therapy, the symptoms were minimal. And what a very curious effect, but a very beneficial one, is that if in fact we find that even at 6 months after the initial insertion of pellets, the symptoms are coming back, but they're not as bad as when they started. And a couple of the trainees that I had, that are present, will document to that, is that the patients can feel the symptoms coming back, but they're never as severe as when they first came in for their first initial visit. And from that point on, those symptoms never get as bad as they were initially. Never. Because that promotes, that continual flow of hormone promotes a wellness that it can't be matched with other forms. Dr. Studd in the American Journal of OBGYN, in case you treat osteoporosis, try and reproduce this number with any other form of therapy orally. It'd be very difficult to do. Oral estrogen maybe gives you a 1 or 2% increase. This is 3.5%. In fact, this study pressured the English health system to basically recommend that the usage of pellets should be employed in the treatment of osteoporosis, because testosterone helps stimulate the osteoblastic activity in the bone. And I don't care how much calcium and how much vitamin D we give, if you don't reproduce a normal physiologic osteoblastic activity, which can only come with the proper testosterone therapy, you will not increase that bone density at the maximum rate that you possibly can achieve. You need testosterone to stimulate those. This is a compilation of studies, not only of Dr. Studs, but also Linzman and all, and what they showed was this. The oral forms, the patch form. Look at the vertebral column in the patient treated with pellets. It's phenomenal. I have so many stories like this that I can share with you. And of course, the poor controls continued to lose their basic, bone density. How safe is it? 2 seconds on this. In clotting studies, since it's a non-oral form and it approximates what the human would normally have in their system, so because your own estradiol and testosterone don't promote clotting factors, but if you put it in the liver and get those clotting factors going, you will promote problems with your clotting studies. The ability for oral estrogens, what are the problems we have with those? We have problems with roller coaster effect. You get reversal of ratio with conjugated estrogens, breast stimulators, fluid retention, first pass metabolism through the liver. You got to take something every day, and whether or not you believe that part about the breast cancer. Types of problems with patches is that even though the estradiol levels are better than pills, the adhesive problems are always problematic for us. The adhesive, your mind up? I'm done, huh? All right, let's see. All righty. This is the advantage of pellet therapy. It keeps the estradiol to estrone ratio 2-to-1. You get a steady state of hormones. It basically has no problem with compliance. If a patient has an intact uterus, they have to take progesterone. How you administer that progesterone will be to your own selection. Minimal weight gain, if any. It's the best method to increase bone density, and there's no evidence it increases the chance of breast cancer because it does not stimulate breast tissue. This is my own study, 10 years of experience with 976 patients in my study group. The one patient who got breast cancer was in the first 6 months of her therapy. It takes 6 years for dysplastic cells to basically, or I should say, cancerous cells to show up on a mammogram. So therefore, if we're talking about this, the longer people are on pellets, the less that they have in the... I should have had 18 to 20 cases of breast cancer by normal statistical analysis. I had one, and that was in the first 6 months. I will tell you that this group now is 6 years from that, and I've had 2. I should have had another 30 or 40 by now. There's a study out of Germany which demonstrated 20 years of experience giving estradiol pellets to women, and the control group had higher incidence of breast cancer than the estradiol-treated patients because they are physiologically normal. I'm all over the place, by the way. Thank you.